Can we start? Golden girl. Always sitting. Okay. Now we have we want to quickly look at drugs for constipation and diarrhea. We'll revise this. Now I believe the time we talk about this, so that constipation is what most persons will experience in their lifetime at one point in time due to their level of physical activity, the food, and a lot of other factors. And so maybe an acute constipation is not really a problem. That once people could be constipated once in a while, but it becomes a problem when constipation becomes a chronic condition. So, and I think we said that constipation is more common in women than in men. It is backed by facts that constipation is more common in women than in men. So, I remember I also said that I should not be comparing my pattern of bowel movements with maybe Adima, for example, or Messi. Because if normally I use the toilet 3 times a week, that's what I do normally. And somebody uses toilet every day. Do you understand? So because somebody uses the toilet every day, and I use the toilet 3 times a week, does not mean I'm constipated. Because if it has been how I use the toilet normally, I'm not constipated. So in talking about constipation, you are actually comparing your current pattern of bowel elimination with what used to be. Which was probably your diet and figure. So if all you've been drinking for 1 week is custard and ogiopa, you don't expect to use the toilet. You just go and urinate because you've been eating light foods. So you cannot eat raw veggies. You eat serious heavy calorie foods and not eat. So if that happens, so you begin to feel like probably there's a problem, and so most of these things will need maybe a proper diagnosis in the hospital. So acute conditions don't sound the problem. It's when it comes to chronic. So the same thing with diarrhea. That diarrhea could happen normally. Diarrhea can accompany some come as side effect of some other drugs too. But diarrhea too will be a problem when it becomes chronic. If there are things that happen, maybe acute, maybe because of for some basic reasons, probably GIT infection, some other things. There are things that you can cure, but in both ways we need drugs. So we say that for constipation majorly, which is what in constipation, what do we have here? We have what? Reduced GIT motility. That's what we have with what? Constipation. Whereas in diarrhea, we have what? Hypermotility. Hypermotility of GIT. So majorly, the class of drugs used here are called laxatives. So laxatives are the drugs we use here to deal with any problem of constipation. And laxatives are of different types. So in talking about that, I don't know, I think I skipped some key concept. So I think I will just go to talk about, okay, I think looking at laxatives here. So in looking at laxatives, we look at the different types of laxatives. I think we mentioned like close to 5 or 6 of them. So we have stimulant laxatives, right? We have osmotic laxative. We have what again? Saline laxative. We have stool softness. We have bulk forming laxatives. We have lubricants. Lubricants, laxative. Which one again? Opioid antagonists. Opioid antagonists. We have all of this as subclasses under this laxative. So, example of our stimulant would be what? What do we have here? Bisacodyl. What else? Bisacodyl, sinusides A and B. Sinusides A and B. For osmotic laxative, what do we have here? Sorbitol. Osmotic. Glycerin. We have lactulose here.
Yes.
Lactulose. Example here. For saline, what do we have? Magnesium hydroxide. Magnesium sulfate. Sodium phosphate as the typical one. Saline laxative. These two softeners. We have liquid paraffin is the one majorly used here. And it's even used a lot in adults. Is what is frequently prescribed. And what? Docusate sodium. Docusate sodium and calcium. Docusate sodium and calcium. There. We have bulk forming laxative, which seems to be natural ones or the safest. We have psyllium, wheat bran, methylcellulose, etc. Polycarbonyl there too. Okay. Polycarbonyl. We have polycarbonyl here. What do we have for lubricants? Mineral oil, usually. Mineral oil. Then for opioid antagonists, methylnitrazone. Okay. To quickly run through this again. So, we said that stimulant laxatives, how do they act? We said that they do what? They cause seasonal irritation. In a way, I don't want to use English for. What we want to do is what? There is reduced GI motility. So stimulant laxative, not using the word stimulate, what they do, in a way, they cause a form of irritation that ensures that the GIT, there is peristalsis, increased peristalsis. So in a way, they are a kind of irritant. They kind of irritate the stomach and produce a reaction that will lead to forced peristalsis. That is, I think, how we discuss our bisacodyls, sinusides A and B. Then looking at our osmotic laxative and how they are different from maybe saline, because sometimes we put them together like osmotic and saline laxative. So we talked about osmotic. From the function of osmotic, like it would pull what? Is it pulling water? Yes. From the surrounding tissues into the GIT, into the GIT mucosa, because one of the reasons why some people are constipated because probably they didn't drink a lot of water, or water is removed from their feces, so the feces becomes too hard. too hard in some cases. In some other persons, what may be the problem could be that there is a problem of blood supply around the ileum. So if there is poor blood supply, maybe because of a disease, there is poor blood supply. That means some of the cells and tissues around those areas are probably close to dead or dead. So you will not expect normal stimulus to come from the brain to the DIT and go there and causes contraction. So that's what happens to some persons. Just what a water problem, a continuous. Some persons just what a reduction in motility. For some persons, it's like a blood supply problem to that place. So in osmotic laxative, we need is it drags water, pulls water from the tissues and brings it there to make sure that the feces become what softer. So when it becomes softer, it is easier to push out. We have saline laxative. What the saline to do, although most of the time, wherever you have salt, you always have water to dilute it. So is there much in between our saline and our osmotic laxative in their function?
No.
So they will draw water. So I think some people will probably put them together. That so when you look at what we have, similar laxative is doing because it's in a way it irritates. It brings an irritation that will cause somebody or the individual to probably expel what is in GIT. The osmotic and saline in a way too, they pull water into the small intestine, large intestine area to ensure what feces can be removed. Then we have these two softeners like liquid paraffin and sodium and calcium. What will this drug class do? In a way, they must reduce the friction in this same space by bringing, is it fluid, or should I say reducing friction, making the place probably should I say more slippery to ensure what? To ensure a free flow. Should we call it a flow? Like a smoother journey for the feces to move out of the body for the liquid paraffin. And I said that liquid paraffin is actually the one that is most prescribed for adults, especially geriatric patients that have issues with this. Although it is said that it is better to use any natural means to prevent constipation rather than rely on drugs, because once a person begins to rely on drugs, the body begins to lose its proper mechanism to control, to bring about normal defecation. So with our stool softeners, let me check here. So they are non-asphytic agent and they also draw water into the stool, causing it to soften. So they want to soften the stool and reduce, so they must be able to reduce friction. So that when somebody goes to the toilet, you're not bringing out blood and feces. You are not having like some persons, the feces in part is so hard that it tears part of the rectum and anus. So in some cases, and so you want to prevent that because that could lead to infection. So the other one here is at the bulk form laxative. We believe that the bulk form laxative are the safest class of laxative. In some persons, you can even use it indiscriminately because what they do most of the time is that they add bulk to the feces. So they add bulk. So adding bulk means that what? They also draw water into that space that ensure that defecation is possible, faster and smoother. So they are mostly natural substances, wheat bran, psyllium, methylcellulose. And we know for a fact that human beings, we don't have the capacity to digest cellulose because it's usually ruminant animals, herbivores, that digest a lot of cellulose in their plant-rich foods. So for most of us, eating foods that are so rich in cellulose means that they go to form roughages. Roughages will attract water into that space, and eventually what you should have is the individual should be able to go to the toilet more frequently with little to no obstruction. For our lubricant laxative, for our bulk forming, lubricant laxative will involve the use of mineral oil, and since mineral oil and probably two substances are oily in a way, these two type of laxative may affect absorption of what fast soluble vitamins, because it will lead to the person will be consuming drugs that are possibly highly fat soluble. So, and since the person will tend to excrete those two, it will affect the absorption of vitamin A, D, E, and K. So there may be need for supplementation of those vitamins in the diet. And lastly, there we have opioid antagonists, metronidazole. Now, while persons on opioids are given opioids which should be addictive, are given these drugs to block the transmission of pain centrally, which also affect what peripheral transmission of pain. So whereas most of the other drugs you give, the opioids, will cross the blood-brain barrier to block pain, metronidazole here would only block the effect of the opioids. Opioids will cause constipation in the GIT. So metronidazole is only blocking that effect of opioids in the GIT. So it will not cross into the brain or spinal cord, into the BB, because if it does cross, it will reverse the blockade of the pain. You've given probably maybe a cancer patient or a person that are on drugs that cause the pain, they will be given opioids to block pain, or those that abuse these drugs to block pain. But if you have given it, we expect that this drug should not cross into the brain to reverse the effect of that pain. Because if it can cross, there will be no need to have given the opioid in the first place. So their primary use is in the fact that they can block or reverse the effect of opioid in the GIT. So that one of the assignments that causes constipation is reversed here. So a person on opioid to relieve pain can also be given opioid antagonists to ensure that they will not be constipated long term. So the treatment here are usually for maybe chronic constipation that will last for up to 3 months, not a constipation of a day or a two that you could just resolve, that can be solved by diet or increasing physical activity, level of exercise. And so a lot of people have issues because of their diet. They don't drink water, they don't eat well, they do not exercise, all of those things. So drugs will not solve that problem. So if it's a problem of lifestyle, you have to deal with the lifestyle first, not just resort quickly to drugs, because drugs over time may affect some of these muscles that are involved in excretion and in ingestion, and they lose the ability to control the removal of feces. So that's what we have. I think briefly that's the summary of what we talked about here. Then we talk about the dose, which I will not go into now. So we talk about the therapeutic outcome. You want to relieve abdominal discomfort. You want to improve passage of bowel contents out of the body within a short space of an hour. Then you want to also look at the nursing process for laxative therapy. That first of all, you must determine the pattern of bowel elimination. Is this person actually constipated, or does this person actually have diarrhea? How long has it been? What could be the cause? Is it caused by food or by other drugs? Then I think we also talked about that you discuss the symptoms involved with the person. So there is always an assessment, history, medication history, and lifestyle is important. So you don't just give drugs for those conditions. Then you're looking at the level of physical activity of that person, which I talked about. You're considering the bowel elimination. You're looking at the nutritional history of the individual. Then in some cases, it might involve basic laboratory studies. Then the diagnosis, you want to make the diagnosis. If it's constipation, you're looking at, is there dysfunctional gastric motility? Is there really constipation or passive constipation? For diarrhea, you're also looking at the risk for deficient glucose, because, which we'll come back to, the dysfunctional gastric motility, etc. etc. Then you also want to look at the hydration status. You want to consider the hydration status of the individual. Having said this, I'll quickly run over diarrhea and say that for diarrhea, whereas we use laxative here, most of the drugs we use here are called anti-diarrheal agents. And I believe when we discuss this, we say that this agent can be broken down into two categories: the locally acting agent and the systemically acting agent. For anti-diarrheal agent, for the locally active agent, I think we discussed, one of them was what? Bismuth subsalicylate. So we say that there can be two classes here: local acting agent and what? Systemic agent. So here we discuss one of them to be bismuth subsalicylate, which I think I should quickly run over. So that for the locally acting agents, that they do not produce a systemic effect. That is one of the things we discussed. We say that these agents are able to absorb and also adsorb. So in discussing it, a person that has diarrhea has hypermotility of GIT. What do we intend to do? It is important to understand what caused the diarrhea. If it was caused by maybe a poisonous substance or an irritant, we need to remove that irritant. And in removing the irritant, it's better to give a locally acting agent, that because those agents are able to absorb the irritants from the surface of the GIT. So it removed that. It also absorbs water. So by absorbing water now, it can now increase the consistency of the stool, so that digestion will occur normally, absorption of nutrients will occur normally, and the person can use the toilet properly. So that's why we have local acting agents like bismuth, then we have the systemic agents. So coming back to the systemic agent, I think a lot of them are, we have Lomotil, right? I don't have to be branding. We have Lomotil, we have loperamide, I believe. Loperamide, I think have a chloride. We have what again? This thing is dry. Go ahead. Diphenhexylate. Diphenhexylate. We have diphenhexine. So what do they do? If a drug acts, like I said, systemically acting agent, it means the effect of these drugs might be felt outside the intended area, which is the GIT. So what these drugs will do is what? One or the other, they would affect parasympathetic innervation to the GIT via the cholinergic nerve fiber. I think that's what we discussed, that in blocking acetylcholine, it not only blocks the function of acetylcholine in the GIT, but it blocks it in other major organs and tissues. So in looking at this, let me see. So systemically active agents act through the autonomic nervous system, which is one of the branches of what? The peripheral nervous system, that they reduce peristalsis and motility of the GIT. They are the same thing. If you remember, we talked about antispasmodic drugs earlier, that antispasmodics will do two things. They will reduce motility, they will reduce secretions. So this one does the same thing, allowing the mucosal lining to absorb nutrients, water, and electrolytes. leaving a forms 2 in the colon, e.g. diphenhexylate, loperamide, and certain anticholinergic agent. So we have some, I didn't put anticholinergic, but we have some of them there. So systemic agent would reduce motility, will also affect secretion here. So by reducing motility, it allows the stomach enough time to absorb nutrients. That is the implication, because hypermotility means what? The movement is so rapid that digestion is not complete and absorption is not effective. So systemic agent through the autonomic nervous system would reduce motility, slow it down, so that the body can absorb the water and nutrient out of the fluid, and it now leaves a forms 2 to be excreted. But the problem might be that if the diarrhea was caused by maybe a poisonous substance or an irritant, systemically acting agent will cause that agent to stay longer in the body. So in a way, it may reduce motility, but once the substance is staying longer, you still have more of the same thing, diarrhea, over a long period of time. So that is what we discussed here. We mentioned the examples. Same thing like the nursing process involved, the premeditation assessment, how the patient is assessed for this. Yes, the one I didn't mention here is under local acting agent. I mentioned the Lactobacillus acidophilus, which is a bacteria which is needed to recolonize the GIT, because in some cases a person has diarrhea or constipation because of the use of antibiotics. So Lactobacillus acidophilus is given to recolonize that area to prevent the other agent that could cause it. So for we have diphenhexine, diphenhexylate, we have loperamide, we have opium or camphorate tincture of opium. So we have them there. So it's just important to remember that systemically acting agent we have there the autonomic nervous system. We affect the vagus nerve, and via the choline nerve fiber we affect acetylcholine release. And this would also may have other effects outside the GIT. That is a major area there. Now, moving on from this, I think the last area that we discussed was drug use in nausea and vomiting. And I believe we discussed how nausea and vomiting happens to be a normal side effect of most drugs that are given. The nausea, some people feel nauseated, and some people eventually go beyond nausea and actually vomit. So that nausea and vomiting, there is a control center up here around the hypothalamus. We have the CTZ chemoreceptor trigger zone that is linked to the vomiting center. So we need stimuli to come, maybe from the peripheral stimuli to come towards the CNS to the CTZ, and from the CTZ to the vomiting center. So this stimulates the actual act of vomiting. So in discussing vomiting, we say that vomiting could be on different types. We have vomiting that is we have CINV, chemotherapy-induced vomiting. We have radiation-induced vomiting. We have people that have to deal with motion sickness, so which will affect the labyrinth of the ear and all those areas. We also have which other type? We have RINV, CINV, motion sickness. Then we have part of that the psychogenic vomiting too. That has to do with visuals, what people see, and how what you see can cause you to throw up. And since there are signals sent from the peripheral to the CNS and back to the GIT to cause vomiting, so that people can train themselves, condition reflex, to prevent vomiting. That normally you would vomit, but via training you can stop that, you can cut short that cycles. Not all of the cycles, the one that is psychogenic. So you can see something and want to throw up, you can also see the same thing and cut the circuit intentionally, consciously, and not vomit. You feel like vomiting. So having talked about that part of vomiting, I'll just move to the class of drugs here. So we have majorly, I think I'm have to clean the book. We have dopamine antagonists that are used. We have dopamine antagonists that are used. We also have dopamine antagonists.